Whenever you tell me to start.
I think a couple of people will still walk in, Shankar, but I think
We should go. Okay. Good morning and welcome. As faculty director of the Hamied Research Fellows Program, which the Mailman School of Public Health runs in concert with 11 to 12 public health institutions, it gives me great pleasure to welcome all of you to this seminar by one of our visiting fellows, Dr. Shankar from the Tata Institute of Social Sciences. The Department of Socio-Medical Sciences, which is also my home, is Shankar's home base, which is where he's in residence, and his mentor is our chair, Kathy Sikima, and she's also his faculty host. And Shankar's work clearly has a lot of synergies because he works on global mental health programs. And the rationale behind the Yusuf Hamied program, which is something that I wanted to briefly outline to all of you, is that it's a bilateral exchange program, which we initiated about 5 years ago. It's based on sustained research collaborations and an exchange of faculty, both between India and the Mailman School of Public Health. And the aim is very much to improve the public health environment, treatment access, and population and family health, particularly to address the key public health challenges in India. The program was launched before the pandemic, and I'm very, very thrilled to say that Dr. Das's focus on mental health during the COVID-19 pandemic, it couldn't be more relevant, and it's one of the critical issues as to how everything ensued in India, which we are very excited to learn about. He's from the Tata Institute of Social Sciences, as Kathy will tell you, and it kind of tells you a little bit about our public health institutions. The Tata Institute of Social Sciences has been really critical since it's been founded in 1936 in addressing, both as a school of social work, but also public health, pioneering policy reform, particularly labor welfare in Bombay and all across Maharashtra and Western India. And it's responded to public health crises, particularly to floods, to the Bhopal disaster. So it's very well known in India, and we are delighted to have Shankar with us. For those of you who have an interest in this program, please reach out to Caitlin Hawk, whose email address is cmh2197@cumc.columbia.edu, particularly if you want to connect with Shankar. Welcome, Shankar. Thank you.
Thank you, Kavita. Can everyone hear okay? This feels like the mic's a little far away, but as long as you can hear well. I'm Kathy Sikima. I think I've met most of you, or I saw you introduced at Assembly. It's a pleasure to have you here in SMS. I'm the chair of SMS. Thank you, Kavita, for beginning the introduction. I think, Shankar, we've said your titles multiple times, but we're pleased that you're here from the Tata Institute of Social Sciences, where you're a professor there, and as noted, Dean of the School of Health Systems Studies. So we're excited to have you talk with us today. A couple of things of background that you may not know. Shankar has 3 master's degrees, and they are in related fields, but we could note what they are, or you could guess what they are, teasing. In social work, and also in international health policy from the London School of Economics, and a Master of Philosophy in psychiatric social work, with his final degree, a PhD in applied psychology from Mumbai University. So related fields, but interesting way to intersect those areas. You may or may not know that he has spent time in the US before. He actually did his postdoctoral training in chronic non-communicable disorders as a Fogarty postdoc fellow at the University of Florida, Amalia. So you can talk Gainesville with him. She's from there, Shankar. I don't know if you learned that the other day in our meeting. He also was a visiting professor at the University of Vermont and taught a summer course on integrated and holistic health practice. This makes a lot of sense given his commitment and expertise and avid active yoga practitioner and certified educator. So maybe after pizza, we should do some yoga, Shankar. Okay. His interests lie in developing greater mental health care access and utilization, as well as how alternative mental health approaches in cross-cultural settings can be used for preventive and health promotion areas at a population level. I do want to say one thing, that as I looked through his CV and we talked more, the connection on mental health was, the most obvious current one, but we've also both worked in HIV/AIDS for decades. And so that's actually, that was always the component of what I looked at that sort of turned me into a global mental health person by working around the world in HIV. So it's really a pleasure to have I guess, a kindred spirit, is that the right word to say? And with lots of goals of developing relationships further. So, okay, we gave you enough time, Shankar, to be able to get your feet.
All right, very kind words, and I think it is a lot of, you have raised my expectation and bar. Anyway, thank you so much for this wonderful opportunity. It is a great pleasure and honor to be amongst you today and share some of the very, very rudimentary field exposure during the time of COVID. And especially this experience is not from just a field, it is living with the COVID itself has given us a greater value addition to understanding mental health. And I come from Tata Institute of Social Sciences, but today I will be talking on mental health and psychosocial aspect of COVID, particularly looking at different challenges and different responses. First of all, I really like to express a huge amount of gratitude to Professor Dr. Hamied, who has been instituted this Hamied Fellowship for all of us. Since 5 years, we have produced many fellows, and therefore it is my heartfelt gratitude from my side on behalf of my colleagues here as a fellows. Dr. Hamied is also known in India as a greatest philanthropist, and as well as he has been a great known face in the CIPLA. And during the time of HIV and AIDS, he did a great job in terms of saving many lives, millions and millions of lives in Africa. So that's the way his history. He has been awarded by one of the highest civilian award called Bharat Bhushan in India. So I owe greater indebtedness to him for this wonderful opportunity. Also, I really like to mention special thanks to all the people in Columbia Mailman Public Health, and who has been very kind. Particularly, I like to mention Dean Linda Fried, Kabitha, and Kathleen, Pam, Kathy, Franco, Claire, Vavin, and Kate, and all my dear fellow colleagues here. All right, I believe it is the most rare and greatest of great learning opportunity for me to come and share and to give you a little bit of idea about Tata Institute of Social Sciences, we are almost 87 years old institution. As for Indian standard, it is one of the oldest professional institution where we have at the moment, we have expanded hugely. We are now 5 campuses, 2 is in Mumbai, 1 is in rural district of Maharashtra. Maharashtra is a district closer to Mumbai. And there we have another campus called Tuljapur. We have a teaching, research, and all field action program. We also have set up another institution, is just our Guwahati campus. Then we also have a Hyderabad in the southern part of India. Right now, we have about 19 schools, is a huge school, developmental school, School of Health System Studies, social work. I come from School of Health System Studies. I really tell you a little later. Independent research center, we are 6, and program we run at a master's level and PhD program is 69 program at the moment in India. We have 5,000 plus students in India. They come from all walks of life, mostly average age of 21 to 28. And I come from School of Health System Studies. As you know, there are 4 centers I just mentioned. And these centers produces 4 master's degree program, 3 MPH, 1 master's degree in hospital administration, 2 postgraduate diploma in healthcare quality management and hospital administration. We are already on the way to start another diploma in health informatics very recently, and diploma. All together in our school, we are catering to 415 students. And this is coming back to the COVID sin, without understanding the magnitude of the problem. it's very, very difficult to fathom the kind of a problem we are in the midst of the COVID. If you really look at worldwide, the population of 8 billion people, and largely if you see large number of people are already inflicted with the COVID, at least number of cases is 9% in the world. It's also is a huge amount. And USA found to be 32% of the total cases, and death rate is a 0.35%. And recovery rate is also very good to 98%. Similar, if you come down to India, our recovery rate is 99%. And India also has a huge number of cases, 33.2% of the total population with the case load. At the same time, our death rate is fortunately 0.04%. It's something to be, something to be really looked at very carefully. This experience, how we have learned from the COVID, with the 1.42 billion population, highest in the world today, we have managed pretty well. The coronavirus of India, just about, 23rd, 2 days back, if you see, again, there is another spike coming up. It's another really very frightening situation. Government of India is again pulled up their socks, and there is a huge amount of interventions, huge amount of investment has started because to prevent any kind of eventuality. If you really look at, we have almost 10,112 people coronavirus in last 24 hours, and you know that 29 people have lost their life. And if I see this, if I come back to United States, it's not so good too. We have just about last week's statistics say 94,142 people are with this. All right. So I should be hurrying up because I have been, I'm sorry. But coming back to the very important area of our first wave, second wave, third wave, and we don't know what all waves are going to be. But the main problem, if you really look at, the wave was the first wave, if you really look at, the largest number of the cases where we have the highest in the second wave, and that was sometime in the March, April, May, was the highest. If you see that highest caseload, which we have seen, was 4,09,300 in the 6th May. That was the highest number of cases infection on the second wave. Highest death was also observed, almost 5,107. It was absolutely chaotic situation in the country. If you really see that, the first picture, if you really look at, it has been gone from there. First picture, if you see that it is the sources are from the Jumbo COVID Center. There's a huge amount of, hallways, sometime in the conference hall, sometime in the hotels, hospital, colleges, universities were turned into COVID, Jumbo Center, where they have been treated people absolutely free of cost. And then the death was so much so, people, you can see that kind of a resilience people have. It's a dead body taken in the more of a middle-class community, but still if you say how people's reaction in this, as if death has very little meaning, because they have seen the first wave, and second wave has made them some way, I feel is so much of resiliency, and there is hardly, death became part and parcel of life. Everybody was worried, is it me is the next case? And that was the kind of a fright we have during the second wave. We have seen deaths in our own floors, in our hospitals. Hospitals are overcrowded. Private hospitals started charging 5 lakhs already into your admission time. And per day's cost is almost about 50,000 to 1 lakh per day's charge in the hospital. And that is the kind of opportunity they found, especially a very exploitative opportunity for the private sector, but in hospitals. But coming back to this became another reality of our life. number of deaths, what you have seen, you might have seen in your newspapers and all, deaths were like these huge number of bodies were in line for the cremation, particularly burning in our Indian context. 88%, fortunately, today, we are 88% people are already vaccinated. 69% comparatively to India, in the United States, 69 is the vaccination rate. We have this one of the massive vaccination drive in the country because government of India wants to really make sure this all the people, whoever is left out, would be part of this vaccine program. After the vaccination, people have found their life back on the track. Largely, people felt much better, confident, and hope for the future. Coming back to some of the very important background, I quickly tell you is this, the 27th, as you know, we have a first case of COVID in Kerala, and it was reported, as you know, March 11th, 2020, WHO declared it is a global pandemic. And that time we just had about 60 cases in India, all right? Government of India that time responded very fast, very rapidly, and very effectively. Therefore, you could see that. And we have bought sufficient amount of time to really make sure the contact tracing, investment in the public health sector, preparation for our medication supply, all essential drug, masks, sanitations. You can see that all of it was possible because of the long extended COVID lockdown. That was one of the best strategy. It might be sounding very harsh, but ultimately we have won the battle because of this extended. There are a number of studies which suggested that lockdown only save it. Now simultaneously we have seen India has risen pretty much. Those are the days somewhere in beginning of this January 2020, we used to really export all the material, particularly sanitation, sanitizer, mask, PPE kits, everything was coming from outside. That also found to be substandard quality. But therefore, India has really brought a great concept by the present government, and they say that we need to do something called Atmanirbhar Bharat. Atmanirbhar Bharat is a self-reliant Bharat, and therefore we have seen within a rapid span of 2.5 months to 3 months, the production rate has gone up so much, especially all the paraphilias. Especially you talk about where we have a huge crisis, we started producing in supply, and with good quality products has been now become an export country. India was export country to many countries, including, as you know, we are also related to the vaccine. We have helped many of the countries. That's the way it is. And therefore, we also have a Made in India initiative. Made in India initiative, if you really look at, it is a great value addition to Indian manufacturer, particularly low skill manufacturer. And this was found to be one of the very, very successful program. Thereafter, we came to the digital India movement. Therefore, we did not have much of a social contact, and that everything became online, telemedicine, online consultancy. There are different apps, okay? And also digital India movement, we have seen something called your Arogya Setu. Arogya Setu is one of the apps on your mobile. Every applications you can use it in terms of contact tracing in your neighborhood, so that you are careful with your health and people around you, whoever is infected. This is the first case detection you can see in your neighborhood, so that you are aware of it. If you want to reach out to help, you can go and help. And that's the way we have really made a communitization of our healthcare delivery system. Largely, people participated heavily in terms of helping the neighbors and therefore we have really thrived during the time of, even though we are spiked with the almost 5,000 cases during the second wave. And then we have supplied all this. And then we have come to, largely, as you know, India is completely digitalized right now. Even today, because of this government initiative, even the local vendor sitting on the street has a QR code. Take this QR code and you just do it, and you can pay the money directly, even the small vendors. And that is the revolution in our country. Those are the days when it was initiated. Oppositions, all the parties of political, this is how silly is it? But it is not a silly. It matter was proven to be one of the best successful program. Right now, India is towards absolute digital medicine, and it has been found very, very helpful. All right, coming back to some of the very important issues, critical challenges of COVID, as you know, it is a humanitarian crisis all over the world. From all over the world, we have all psychiatric morbidity, mental health issues has been published enormously. The largest number of publications, if you can see, it has come from, even India is the third in the publication, especially in our COVID time. So people have hugely published, and therefore, as all over the world, people have really focused heavily on mental health, mental resilience, crisis, suicide, people living with the mental illness and their crisis, people with the vulnerable population in the prison, homeless populations, and they had possibly double jeopardy in terms of living with the COVID challenge. So this is one thing. And also, if you see that our lockdown was the longest in the world, 2 months, 7 days, it was the highest number of days. And that was the time when we have a huge number of problem related to people who are migrant workers. Therefore, you might have seen, I will be discussing a little later, also people with the existing mental health problem. There was hardly anybody to cater to. We have a 42 government mental institution. Still, we are very traditionally British system of mental health care. But even though we have tried to really integrate mental health in our district mental hospitals, medical colleges, primary health centers, but the success of this program of national mental health program, district mental health program, what we expected in 1982, it has really taken a good shape, but it is not up to the mark, which needs to be revamped and reviewed, and possibly we need to further work towards it. All right. And lockdown, as you know, there is a huge amount of psychological difficulties of the vulnerable population. I just tell you, the children was absolutely out of the school. They had no neighborhood friends. They're locked inside. A large amount of children in the cities started becoming more and more putting with the huge weight, and they were online classes. There's a huge amount of problem related to their obesity, disturbance in the night, fear of losing someone, very significant one, either father or mother. All these were the great challenge. All right. This is from Lancet. I would really like to highlight here is this mental health vulnerable population, people with the severely ill, people with the neuropsychiatric disorder, behavioral disorder, as well as the people with the developmental disorder, are basically socially excluded during the time of COVID, where possibly people with the homeless and all, I say they needed more critical attention to this particular time of isolation and lockdown, and people were absolutely to themselves. Even myself as a COVID volunteer, I cannot go out. Police will catch me and say that, who are you? That's the reason in the local authority, we have an identity card. We have to get it issued and say that I am so-and-so. And once you have that card, you are COVID warrior. They have respected you in the community, hospital, whatever we have done. I'll just come back to some of the other issues. It has open challenges like social and economic crisis and issues, huge amount of mass unemployment, people become underemployed, and large number of people have been, downsized from the big corporate hospital. People lost job, complete unemployment. And therefore, there's a lot of disturbance in the family dispute, marital issues, family violence, living together in the same home. Many of the theorists in mental health said expressed emotion theory, that living together in the same family, when you are connected with each other so closely, there is supposed to be more of a conflict. Expressed emotion is a theory where there is a lot of expression. Either it is a positive emotion or negative emotion. Largely, it becomes at times very contaminated, living together in the same environment. That was the main issue there. Gender-based violence we have seen largely, and the families, there are a number of women were battered. And that has been a news anecdotal informations are available. There's no a good study to really see that in this way. All right, I just like to flip this quickly. I just come back to the largest part of the crisis. I'm going to give you a few cases so that you understand what was happening there. And one of the COVID lockdown time, we have seen that over 8,700 people, many of the migrant workers died along the railway track. This is the statistics given by the railway board, who keeps the data of all the deaths happening on the railway or the railway tracks. So understand 8,700 people died. Did they commit suicide by jumping? There is no data. Are they while they have ran over while train was coming? We don't know. But during that time, lockdown period, no passenger train, no train for passengers were running. It was completely blocked. Only time was there, only the goods train was running that time. People took from the cities to their villages because they wanted to just by any means they wanted to get back, because many of the people in this group of people, whenever we have gone to Dwarka is Delhi is one of the suburban, where we have gone and asked, why are you waiting? They said that we are just waiting for the next bus. Anyway, we like to go. Why do you like to go? Can't you stay? We have facilities there. They said that we have no food. I think I have written somewhere, my employer did not pay my salary. He closed the factory. Here we will die of hunger, not COVID. Here in the city, we'll die of hunger, not the COVID. Better, they just left. Immediately, you can say, millions and thousands of people started moving from the cities, main cities, 4 metropolitan cities, township to their remote villages. Sometime almost about 15 to 35 kilometers they have taken on the road. On the road, many of the cases you found that they have not made to their villages. That entire family met with an accident, met with the hunger, and then finally they died. This is the state of affair. If you see that during the time of that lockdown, when possibly I was just trying to tell you 60 cases, fortunately, there may be some of the cases they have taken this virus back to their rural area, which was absolutely serene, and there was no issue related to. But we have seen there is a virus transition from our urban to rural areas too. All right. And I just like to also highlight some of these issues that we have seen during this time. We have seen there is an increased amount of child labor. As you know, India at this moment, we have 10 million children are employed in a child, as different industries, and especially the bangle industry, which requires, nimble finger, sometime in the fireworks factories. All these are very problematic situation on that side. And here you say father did not have any means to fend for themselves. Mr. L finally given the child 13 years to the traffickers, to a bangle factory. And therefore, once the child 13 years old was sold, it was very difficult to get back the child in the family to get integrated. These are the challenges people found. And he said, and there is no way he could help himself because they were otherwise going to die of hunger. All right. Now, this is I just like to quickly tell you how many people we have lost, the doctors during the time of COVID. Dr. K. Agarwal, one of the most vibrant, cardiologist, well-known. He was supposed to be one of the best crusader during the time of COVID. And we have seen all the YouTube channel. He has reached out millions and millions of people through his, work. He died, and there was almost 1,000 doctors in the second wave that died because of the COVID. 1,000 recorded cases with the Indian Medical Council. We have innumerable number of such people who died, but there's no record. This is a one problem. This was written somewhere in one of our publication. I just like to come back to the challenge of population where we are. And many of you as a population scientist, many of you will say that it is a demographic dividend. Yes, it could be. And therefore, China and India made on the top of the trajectory for the economic development. This is one argument. More hands and more productivity, more people and young people, therefore the productivity is high. This is one side. The flip side of this is also there is a lot on this side. It is overcrowded cities, poor infrastructure, poverty, blah, blah, blah. This is the challenge of India. And then you can see this is the kind of a space used most of the metropolitan cities. All right. I come back to this. What is the effect of overcrowding and mental health? All studies found, many in India and abroad also. One of the best study which I could tell you is the Health Foundation analysis of UK has found there's more the overcrowding of the adult people living in the cities. There's a greater amount and greater propensity for mental health distress and mental health depression as well as anxiety. There are a number of studies of this nature. This I just wanted to tell you. I just like to also come to what was the case of Dharavi. You must be reading about it. We have the three basic model, one of the very successful model of COVID containment successful stories. One was Dharavi model, second was Bhilwara model in Rajasthan, and third was Kerala model. They have done a wonderful job in terms of making cases, successful cases of containment and reducing the number of caseloads during the time of when there is a spike was high. But however, it did not last for a long. It was absolutely like a bubble. It burst in Kerala. And still later on, we found that in the first wave we did it, but second wave, it was absolutely difficult. But however, Dharavi is one of the very successful model, but they have, that it is Asia's largest slum. We have almost about 227, 136 people living per square kilometer. You can imagine that 8 to 9 people living in 10 by 10 tenement, 10 by 10 apartments. Is that kind of a situation. They live in shift. One group of people live there, sleep there, and night shift people go back and morning people come back. And this is the kind of a cost of living in Mumbai city, particularly Dharavi. Dharavi is known for a large amount of small scale industry, leather, you talk about pottery, you talk about, it really means money. And if you really look at it, is a hub of about 15,000 small scale industries. And today, if you really look at it, makes turnover of business of $1 million. This is the statistics by many of the very reputed journals. As you know, suicide is very high. It has increased during the time of 67% by many of this study, 67% in the 218. It is coming from National Crime Record Bureau. And this is one of the study also I can tell you. This is done by, Sripad and many of these, they found that these studies are showing that during the COVID time, especially in 20s, cases loads were very high. But corollary to that, India is also known for farmer suicide. Farmer suicide is also another issue in India. We have lost many farmers, particularly in Tamil Nadu, Andhra Pradesh, Maharashtra. All these states have found huge number of people. And also there is a great number of difference between landless laborer versus landholding agriculturist. landless laborer has lost a great number of lives. The increase of death by pesticide consumption was about 18%. So this is the kind of a state of affair, especially when we talk about, even in the rural areas, COVID has touched every life, everywhere, wherever they were. Now, coming back to the statistics of our state, as you know, Maharashtra has the highest number of cases of farmer suicide, and the lowest is the Tamil Nadu. Tamil Nadu model is little successful. I will tell you the reason. WHO has, World Health Organization, invested many research grant, and particularly there's a lot they have been doing in terms of experiment of preventing such suicide due to consumption of pesticides, easily available pesticide, and that's the way they consume. One of the mode of consumption is this. Coming back to analysis of media report, it is one of the study well done. It was Dr. Soumitra Pathare, and they have said that there was almost 67 increase in our suicide rate from 1819 to 2021. This was one thing we have seen. But largely we have seen the men folks, about 71% people died, and especially the men. And there's a similar experiences in our studies too. Now, largely people have a mode of suicide were largely hanging, 64%, and poisoning is just about 8%, and jumping in front of the train is just 2%. Now, coming back to the small conceptual framework, which we thought, looking at this entire gamut of issues, we thought this is the best way to explain what was happening. One side is your proximal factor. These are the predisposing factor, which basically led to the mental health, either it is good or bad. Distal factors are those vulnerability and risk factor which led to the outcome in their mental health. If you really look at the proximal factor, family issues, violence, and abuse were very high. It has been done with a huge content analysis of our news media report that was easily available, that what we have done. And the stigma related to COVID was also found to be high, and all in a proximal factor, any health preconditions, people living with a comorbid issues, for example, asthma, for example, hypertension, diabetes, coronary heart disease, all this is also part of their mental health. It is a further worsen their mental health condition. And also economic crisis one of the proximal factor. Coming back to the distal factor, which was fear of infection. Everybody in the community said, am I going to be the next? The deaths were so close, next door, people are dying. Your friend circle, you are dying. The day when I was waiting for 48 hours with the diagnosis for COVID, in India, we don't have a rapid test. Now it is there. During the time when I was infected, it was 48 hours. And that is the same night, Bala Subramaniam, one of the leading singer in South India, just died in the hospital. And understand my condition, living these 48 hours, completely locked from my family, no connections. I was in and sleepless night. People can understand how tough it is. So this is a fear of infection is the highest cause related to suicide, anxiety, depression. That also I will just tell you. And the work pressure was very high and all blah, 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 blah. You can see that there is a protective factor. Protective factors, if you could see the positive thinking, there are also people who have boosted up positive thinking. Number of initiative came from the government of India, mental health support and all. Then is spirituality. The spirituality has played a great role in India. India is a country of yoga and spirituality. Whether you say that it is a science or no science, but the Lancet has already proven the fact, written huge amount of efficacy study related to spirituality, and yoga can really make sure that many of the psychosocial stressor, depression, anxiety can be minimized and sometimes absolutely can be brought to the normalcy. The number of cases are there. Anyway, This is one thing. Also, if there is a good family support in terms of primary, secondary, tertiary, they also do it well. All right. Now, Government of India, I'll close. Government of India has done a lot of work in terms of starting a psychosocial support in all university system. And therefore, we started immediately a online counseling and support system. We have done here, we have given first is that information on most frequently COVID questions, which are clinical, which are frequently asked on mental health question. And once they click all of it, and large number of students we have started with, but we found people where almost 65 years is the highest number, age group of people also responded to our online counseling. And once you click, all informations are there. And these informations are absolutely keeping with the Government of India guidelines, ICMR and WHO. Our informations were absolutely curated completely. And then what we have done is this, and once they have done, we have also said to them, if you are interested to take a test, we have put PHQ-9 to see their level of depression and other mental health issues, and that immediately they have done it. And then what we have got a score, and once they have got a score, we have definitely seen that low, middle, high scores. As soon as they score above 18 to 27, we have immediately given them directly this number, they can come and talk to us. These are our counselors, which are known as professional counselors. They're all mental health professionals. And they basically did the counseling. And after this is a counseling, and PHQ is already database we have generated with the consent, and this data we have analyzed it later on. And this data we have published it, and we found that 46% of the people have reported with the depression. And we also had one question, has this period of lockdown been difficult for you and your family? 76% people says, yes, it is difficult. And this is only happened when we are on the counseling. During the time of counseling, we did lot of data, lot of recordings, and those data with the permission, we have done some of the publications. All right, we also have from the same study, we have seen that what are the psychosocial stressors across all age group. And we have found that it is a negative impact of media. As you know, the media played a huge amount of, I could say that negative impact. It is almost like an infodemic. It was not reliable, exaggeration of the figures, and repeatedly there is something called your COVID meter, and it goes on rotating, death case, death case, and it just keeps on rotating and flashing in all media channels. And that is the reason you see how much it has been pumped in your mind, how much damage it has caused. People are all glued to the either on the screen or in the television. Nothing was discussed, only COVID, and morbidity, death, and fatality. That's all. So this was one thing, that is the impact which they have caused. At this time, Government of India has recently, they have passed a huge amount of, yeah. All right, this is all. I just like to say this is our finding. I just like to come back. And also, we have seen in our counseling of our professional group, we found 3 cases. 3 cases where already reported they have attempted suicide survivor. When we have asked them what has happened, they've already consumed, somebody hanged, somebody tried to jump. So this is kind of a thing only because of the kind of information, overload. And therefore it produces huge amount of anxiety and depression. And these 3 cases could have been, we just reported only out of 432 cases. And we have a response in our interviews, almost about 5,699 people reported on our system. All right. Now coming back to, we have tried to locate these people's subjective well-being. psychological well-being and psychological distress. And you can see that we just 177 people have participated to fill this form of MHI mental health inventory 38 items. And once we have plotted it, we found that is a psychological, distress is at this level. You can see that these are the all people needs a psychiatric mental health help. But psychological, well-being is at that squeezed level. Largely people were absolutely, in a very, very, harassed, or the mental health was absolutely very poor during that time. All right, I think we'll not spend much time. I like to quickly tell you the government of India with the WHO has done a great work in terms of making pesticide not available to the directly available to the farmers. They have brought this called pesticide bank, and it is meant by or women. No, there is no women usually. It's all man will be keeping a very good care, take care of these. These are the community people in the villages. There is a rotatory duties, and they will be only giving the pesticide only in during the daytime, not in the nighttime. And when you have in a home, pesticide can be consumed with the spur of any difficulties they used to just. And this is one of the very, very experimental, very successful project. And Tamil Nadu has seen a drastic, fall of suicide due to consumption of pesticide. This is going to come soon in most of the states. And this is a government of India's new initiative just about 2-3 days back. The government of India is investing heavily. And as you know, SOPs are there, mock drill started, and all the state, about 8 states were sent the circulars to buck up their health system with the different. All right, I believe that these are the way forward. And I think, as you know, it should be capacity building of the people at a grassroots. We don't have that kind of a qualified. Mental health is a misnomer in many of the countries. Everybody says, I counsel, but when you sit down with them, it is nothing to do with the counseling. People are not qualified. We need to have a qualified counselor. There are a good number of counseling program, training program. For example, lay counselors program of Sangat. I think, Vikram does a good work on that. We also have something in integrated rural health and development project. We also do a lot of, hand holding, training, mental health program of your ASHA worker in Maharashtra. Anyway, this is all in short. I think I should close if I can answer if there's any question. Sorry.
That's your close. Thank you.
No, I like to.
Thank you. You can stay up here and answer questions. We'll figure this out. Thank you very much. It's really very interesting and ways to think about what happened in India and thoughts about the United States. You said 2 things that I'm going to remember these terms. Communitized. I like that. I think that's a good word. It's an excellent word for that I may struggle for and use at times. And COVID warrior, I liked as well. So congratulations on being one of those for everything that you did. Let's take a couple questions here. I have some questions on the chat. Does anyone have a question they want to ask right off? Yes, Pam.
Hi, thank you so much for that really great talk. I was wondering about the extent of the problem of long COVID in India and about the ramifications on the mental health system of long COVID.
Just repeat that so they can hear. The question was about long COVID in India.
All right. Now, long COVID, we have a lot of anecdotal evidence, a lot of experience from the doctors, and some of the articles has recently come. Long COVID is a big, still a myth. I believe that it is not a myth, but it is still people think it is a myth. But ultimately, in reality, it is still having a lot of difficulties with the long COVID symptoms. People have fatigue, people who suffered earlier. Now people are non-COVID. They have been vaccinated, but there is a breathlessness, short of breath, fatigue. And next is that number of, cardiac related issues and heart issues and a lot of death related to cardiac arrest. And this is a rampant in Indian situation. And if you say that mental health of COVID versus non-COVID, we had a slide, and we found that people who have never been, with any kind of a COVID, they did not have much issue. But let me tell you, it may be a community hard or the hard immunity where people got infected but did not have any complications or no symptoms. There is nothing much with these people. They are the people, maybe carrier, they may be at risk of, giving this virus to others, but they have hardly really maintained any social distancing, and especially the young people. So this is a kind of observations we have. Did I answer your question? All right.
May I ask one from the chat?
Yeah, please.
So the first, is it still working? Maybe it has to stay in the bucket. Sorry. Oh, it's this one. All right, I thought it was the other one. Here was a solution for us. All right, so this question is about spirituality. And the question, as you were talking about the benefits of spirituality, wondering whether it's formally taught in schools in India, and is it more older, ancient India, or part of curriculum at any level? If not, why not, when India is the pioneer in spiritual practices and such a benefit on health, like how to get it more integrated into learning and practice?
As you know, spirituality is a huge science, the oldest science in the world, like a philosophy. If any subject came in our human knowledge, it is the first thing came to this world is a philosophy. And philosophy is the art of living experience, knowledge of people and their community, and especially the science of morality. All this is part of the spirituality. The spirituality in India, what we believe is a simple term called Ishwar Pranidharana. Ishwar Pranidharana. It is 3,000 years back, Patanjali Rishi, the seer, has given this concept called you need to surrender yourself to the supreme power. I hope you understand. Our mind is extremely gullible. Extremely gullible. We are not confident. We are wavering between conflicts, avoid and approach kind of a conflict all the time. But that is the reason what you need to do is that beyond me, there is some superpower. Believe in it and restart doing certain practices. For example, joining any yoga or meditation club. For example, in India, we have everywhere people are doing yoga. This is first thing. Second thing is also in spirituality, we have a lot of meditation techniques. What we call at the end is that dhyana, Ashtanga yoga, eightfold path of yoga, including asana till the moksha. Moksha is the ultimate enlightenment. Before that, something called dhyana. Dhyana is the meditation. Meditation is nothing but really closing your eyes and getting into yourself and getting in touch with your inner self. How do you get in inner self? You will get to know by certain techniques. And one of the best techniques which has been found called Vipassana meditation. It tells you completely you can go to the moksha stage if you have a long duration of practice. Second thing is also possible, go to more and more what we do is the discourses of our Indian spiritual gurus. You may say that all are fake, but some are true. But listening to them itself is a very elevating experience. Listening to them is a very motivational, gives life and happiness to you. So spirituality can be done in many ways. And obviously in India, we do a lot of teaching spirituality and science. And doctors today, I'm talking about one of the best doctors in India, known as Devi Shetty. All of you know Devi Shetty's program is the cheapest and cost-effective treatment of heart surgery to the children at the lowest of low cost, Padma Shri of India. So that's the way he is also into that spirituality. He may be a great scientist. Ultimately, he follows the same. But that is the way possibly we do it. and spirituality is a curriculum. I come back to United States of America. I was a fellow here, and then there is a one group of people in NIH called CAM, Complementary and Alternative Medicine. CAM brought me to Vermont University to teach that holistic health practice and theory. I brought Indian system of Ayurveda, yoga, all meditations, and that was a 3-credit course. And I was very happy doing a summer course for them.
You're very much a trendsetter, way ahead of the curve. I think any questions in here, and otherwise there's more on chat. Yes, please go ahead.
All your insightful and interesting share. I'm from China, and let me share an interesting similarity of China and India. Farmer suicide is also a great problem in China, and one of the way to tackle this problem is also the restriction of pesticides. That's the similarity here. And I'm interested in that. What's the government initiative of promote the mental health after the COVID-19 in India, as you mentioned, which is a very effective way. Thank you.
All right, thank you so much. Ni hao. All right, so I just like to say that in China, they have also a lot of cases of farmer suicide. And she also said, what is the way the government of India really trying to prevent and promote mental health of, farmers? Quickly tell you, in India, we have it's not just mental health is one issue. Mental health is just one point of the bigger issue. You take care of all the structural issues, their families, their indebtedness, their loan system, their seed, subsidized fertilizers, everything. Once you make their life better, they will definitely not do anything. For example, natural kind of a calamities, a drought situation. What government has to do during the drought? They need to really do some kind of a subsidized, subsidies, as well as some kind of a extending of the loans. These are one way. Obviously, mental health will be better. Mental health is not just treating a symptom. Mental health is making a holistic approach to improve the well-being of the community or the specific group. And as you see today, we have learned a great deal of lesson from your barefoot doctor of China. Today, barefoot doctor of China in India, we started our first community health work initiative through this movement. So I think your farmers are also doing pretty well. But at this moment, I know the crisis in China. So government needs to be very careful, especially the policy program, the support mechanism in this country has to be pro-farming and pro-farmers, welfare.
So I think I want to say thank you again. We may have a few minutes in between transition to class. If anyone wants to ask you a question in particular, please feel free to stay and do so. And it's just been terrific to have you visit with us and for us to think about the impact of COVID in India as well as the United States, and what we hopefully learn, particularly about mental health going forward.
Thank you.
All right, thank you very much.
And thank you for involving me in your global, mental health initiative.
Sure.
I'm really indebted to you.
Sure,
And
certainly.
I would love to associate with you.
Very good. Pleasure. All right, thanks,
you.
everyone.
Thank you.
I'm gonna turn this off. Stop share. Is the recording on here? Yeah. Okay.